Orthopedic Surgery, Chapter 1, Principles of Diagnosis in Orthopedics. The art of diagnosis hangs on systemic gathering of information starting from the patient's history and ending with special investigations. History, proper analysis of the patient's story, is a keystone to reach provisional diagnosis. Since we are dealing with the musculoskeletal system, usual symptoms are mainly mechanical. Mechanical presentations are instability, weakness, deformity, major abnormality in the shape of a body part compared to the normal shape, locking, sudden inability to complete a certain movement, stiffness, limitation or difficulty in movement. It may be generalized as in rheumatoid diseases or localized as in osteoarthritis. Other common presentations are pain, swelling or painful swellings, and change in sensibility. Family and past history analysis is an integral part of the proper history taking. Examination. The patient must be suitably undressed, and the normal limb should be checked first to be compared with the diseased limb. Musculoskeletal examination includes 4 essential steps: look, inspection, feel, palpation, move, range of motion and power, and is completed by performing special tests. Look should be done from all directions, front, sides, and back, for a general shape, posture, gait, noting any obvious deformity, exposed skin, signs of inflammation or scars, local shape, swelling, wasting, and deformity. Feel should be done from all directions, front, sides, and back, for skin, signs of inflammation and sensations, soft tissue, tender points and lumps, bony prominences and joints, tender points, outlines, and fluid collections. Move to check the joint's range of motion, expressed in degrees starting from 0, which is a neutral position. Active, the patient is asked to move the joints or muscles to be tested. Passive, the physician moves the joint and checks for the greatest range possible. Active motion should be tested before passive to determine the painful motions. Abnormal motion is indicative of unstable joint or bone fracture. During active movement, muscles are tested and graded as follows: grade 0, no movement; 1, only flicker; 2, movement with gravity eliminated; 3, movement against gravity; 4, movement against resistance; 5, normal power. Special tests. There are specific tests testing for specific diseases. They are provocative or stress. Provocative stimulate the action of the inflamed or torn structure causing pain or apprehension. Or stress test put the injured structure at stretch, denoting painful or abnormal motion. Diagnostic imaging, radiograph image, X-ray. Radiographic images are created by the attenuation of X-rays as they pass through intervening tissues before striking an appropriately sensitized film. The denser and the more impenetrable tissue, the greater the attenuation, and therefore the whiter the image, such as bones. It's a 2-dimensional image. For this reason, we always ask for at least 2 views, projected at right angles to each other, anteroposterior and lateral, and sometimes special views to distinguish between bones overlapping each other. Computated tomography or CT, combination of many X-rays measurements capable of recording the bone outlines in cross-sectional images, slices, whether axial or coronal or sagittal. Furthermore, the computed data can also be constructed as 3D image. It's particularly useful for showing more detailed bony patterns. A relative disadvantage of CT is the high radiation exposure. MRI, unlike X-rays and CT, it doesn't involve ionizing radiation. It depends on radiofrequency emissions from atoms and molecules in the tissue exposed to static magnetic fields. Diagnostic ultrasound. Ultrasound testing implies high-frequency sound waves generated by the transducer to penetrate the soft tissues and reflect to the transducer again, where they are registered as electrical signals and displayed as images on the screen. It has many advantages as compared with other imaging modalities. The equipment is simple, portable, produces no harmful side effects. Moreover, it can be used to test tissues in motion, giving a dynamic image. CT scan is usually ordered when a better description of the hard tissues, bone or metals are required, while MRI ordered when a better description of soft tissues such as muscles, cartilages, ligaments, nerves are required. Radionuclide scanning. These types of imaging depend on the uptake of radioisotopic material by specific types of cells. Most commonly, radionuclide bone scan implies using the uptake of 99M technetium hydroxymethylene diphosphate injected intravenously by bone-forming cells, osteoblasts, and then hot areas are recorded with a gamma camera or reticulinear scanner indicating increased osteoblastic activity in this area, as in cases of bone infection, tumor, or fracture. Positron emission tomography, PET scan, is a new scanning modality. It implies measurement of the concentration of a biologically active tracer molecule, such as FDG, an analog of the glucose in tissues. High concentration indicates high metabolic activity and the great possibility of metastasis in any tissue in the body. Dual energy X-ray absorptiometry (DXA) employs extremely low dose X-ray at two different intensities and is the most widely used technique to measure the bone mineral density (BMD). It's used in diagnosis of osteoporosis and high fracture risk. Laboratory investigations, blood tests, non-specific blood tests. We have these tests are the most commonly used in practice and used either for integration with clinical and radiological findings to diagnose certain disease or for monitoring of the response to medical or surgical treatment. Common examples are ESR, CRP. Both are non-specific inflammatory markers used to diagnose and follow up infection and rheumatological diseases. Specific blood tests. These tests are used to pinpoint specific diseases with high sensitivity and specificity. Biochemistry. These tests are mainly used to diagnose metabolic bone diseases as gout and rickets. Synovial fluid analysis. Joint aspirate should be done under complete aseptic precaution by a specialist. Fluid should be sent to either biochemical analysis, cytology, bacteriological culture, and antibiotic sensitivity according to suspected condition. Biopsy. It should be kept as the final step in diagnostic process. It's either used to confirm primary diagnosis or differentiate between conditions which are closely resembling each other. Chapter 2. General Principles of Bone Injuries. Definition of a fracture. Structural break in the continuity of bone. Etiological types of fractures. Fractures are usually caused by high-energy trauma. However, sometimes it may follow low-energy trauma if the bone is weakened by disease or fatigue from repetitive traumas. According to mechanism of injury and bone condition, fractures are classified into traumatic, pathological, stress or fatigue, insufficiency or fragility fractures. Traumatic fractures. High-energy traumatic fractures are caused by one of the three mechanisms: direct, indirect, and avulsion. Direct, in which the fracture site coincides with the site of the trauma, usually results in a transverse fracture pattern. If both bone fractures in the leg or forearm, they occur at the same level. Common examples: nightstick fractures of the ulna, fracture of the tibia if stricken by a car bumper. Indirect trauma, in which the fracture site is away from the site of the trauma, usually results in a spiral fracture pattern. If both bone fractures in the leg or forearm, they occur at different levels. Common examples: fracture of clavicle after a fall on outstretched hand, or fracture of tibia after twisting while playing soccer. Avulsion fractures due to sudden forceful pull of a muscle while the bone is moving in the opposite direction. Common examples: base of the fifth metatarsal avulsion fractures occurring when the foot twists with an aggressive protective pull of the peroneal brevis tendon, and avulsion of the anterior inferior iliac spine or the ischial tuberosity in a football player. Pathological fractures. Low energy trauma may cause fractures in an abnormally weak diseased bone. Numerous local and general causes exist. Common examples are local diseases such as osteomyelitis, cysts, primary and secondary tumors. General diseases: hyperparathyroidism, osteogenesis imperfecta, osteoporosis, and Paget's disease. Stress and fatigue fractures. Repetitive low-energy trauma causing fracture in normal bone due to tissue fatigue. Classical examples: march fractures in military personnel and tibial fractures in athletes. Insufficiency, fragility fractures, etiological term used to describe fractures which occur in osteoporotic bone. Osteoporosis leads to low bone mass, leading to failure with low-energy trauma. Classical examples: fractures of proximal femur, vertebral compression fractures, VCF, and distal radius in elderly. Clinical features and diagnosis. History. Proper history taking is essential for the diagnosis. And we have mechanism of injury, complaint, associated injuries, past history. Mechanism of injury: traumatic fractures, a clear history of high-energy trauma, pathological and fragility fractures, trivial injury or not at all recalled, however, a history of a local or general disease or previous pain may be obtained. Stress fractures, recurring overload acting may be recalled. Complaint, usually complaining of local pain, swelling, loss of function, and deformity. Symptoms: they are variable from mild to severe according to the degree of displacement. Non-displaced fractures, such as impacted fracture of the neck of the femur or green stick fracture in children, may not be associated with immediate loss of function or gross manifestations. These fractures require a high index of suspicion for diagnosis, otherwise it can be easily missed or misdiagnosed as sprains or contusions. Associated injuries: asking for associated injuries that follow the same mechanism of injury is important to avoid missing a fracture due to distraction by the other one. Common examples: fall from height may cause associated fractures in calcaneus and spine. Dashboard injury may cause associated fractures around the knee and hip. Fall on outstretched hand may cause associated fractures of around the wrist, elbow, shoulder, and clavicle. Asking about non-skeletal associated injuries such as abdominal pain, breathing difficulty, or temporary loss of consciousness is very important and commonly overlooked. Past history: obtaining full picture about the patient's general or musculoskeletal mobilities is an integral part in assessment the etiological type of the fracture as well as its helpfulness for setting the appropriate management plan. Clinical examination: classical signs include swelling, ecchymosis, tenderness, crepitus, loss of function, deformity, abnormal mobility. These signs are variable from mild to severe according to the degree of displacement. Fracture examination and evaluation should follow a systematic approach. General examination for evaluation of the general condition and associated injuries. Local examination: look for swelling, bruising, deformity, skin condition for wounds, open fracture, or skin stretching for possible signs of ischemia or nerve injury. Feel local tenderness with extreme care in a gentle manner. It's sometimes the only finding as in non-displaced fractures. Move, loss of function, crepitus, abnormal mobility shouldn't be intentionally tested as it could cause more complications. Movement of the joints distal to the injury should be recorded. Special tests: examination is completed by examining for associated injuries, especially in high-energy trauma, examining and recording the neurovascular status of the affected limb. Radiological examination: radiographic image, X-rays. Asking for an X-ray in the trauma setting follow the rule of twos: two views, anterior, anteroposterior, and lateral, two joints above and below the fractured bone for possible associated fracture or dislocation. Common example: forearm fracture, dislocation, and fracture of neck of femur associated with shaft fracture. Two occasions: some non-displaced fractures might not show immediate post-traumatic incident, but might show a week or two later during the healing process. Common examples such as scaphoid bone and stress fracture. Two limbs: comparison X-rays with the injured limb might be necessary if confusion exists. Common examples: pre-existing bone abnormality or epithelial line in children. Two injuries: to avoid missing a commonly known associated injury. Fracture description following these points: site, which bone, which part of the bone, diaphysis, metaphysis, epiphysis. Type: complete, simple, equals two fragments versus comminuted, more than two. Incomplete, fissure or green stick fracture in children. Physical, involving the gross plate in children. Pattern: transverse, direct force, oblique or spiral equals to indirect force. Comminuted equals multiple fragments. Segmental equal double fractures leaving floating in between segments. Impacted equals fragments are jammed tightly together. Displacement: translation equals shift, sideways, backwards or forwards. Angulation equals tilt. Rotation equals twist. Length equal distraction, overriding, or impaction. Bone quality: whether normal, osteopenia more gray, osteoporosis, marble-like, more white. Description of the radiograph equals type of the radiograph plus patient's demographics plus description of the fractured. CT, mandatory for proper evaluation, especially in areas with complex bone morphology, commonly used in intra-articular features, such as fractures of pelvis and spine. MRI, important for proper assessment and diagnosis of certain fractures. Spine fracture, for evaluation of the associated spinal cord and nerve injuries. Fracture dislocation, for evaluation of the associated ligamentous injuries. Stress and non-displaced fractures detects early with high sensitivity, contrary to the X-ray, in which the fractures appear week or two. Soft tissue injuries associated with fractures. Fractures are always accompanied by variable degrees of soft tissue injury and damage. It's considered an integral part of the fracture to the extent that some surgeons describe a fracture as soft tissue injury complicated by a break of the bone and not the opposite. These injuries may range from superficial abrasion, deep muscle contusion, or the most extensive crush injury. In low-energy trauma, such as torsion, associated soft tissue injury is minimal. On the contrary, high-energy trauma is usually associated with considerable injury. Soft tissue assessment is a part of the fracture evaluation and should never be underestimated or neglected. The degree of soft tissue injury can significantly affect the fracture management plan and prognosis. Fractures with considerable soft tissue injury are prone to skin breakage complications, infection from bacterial contamination, especially open fractures, and delay of fracture healing and/or non-union, neurological complications, vascular complications, especially compartment syndrome and acute ischemia, tendon and ligament injuries, ranging from sprains to complete disruption, muscle injuries leading to fibrosis and functional deficit, compartment syndrome, devastating soft tissue injury condition resulting from increase in the osteofacial compartment pressure to a level that decreases the perfusion. If neglected, it may lead to irreversible muscle and nerve damage, usually results following high-energy trauma, extensive soft tissue destruction associated with extensive bleeding, edema in a closed compartment leads to pressure rise, vascular occlusion, and myonural ischemia, may occur anywhere where the skeletal muscle is surrounded by fascia, commonly seen in the leg, forearm, hand, and foot. Diagnosis is essentially clinically and requires high index of suspicion. The 5 P's. Early alarming sign is severe swelling and pain out of proportion to the situation. Early physical examination may reveal severe pain on passive muscle stretching due to muscle ischemia, paresthesia due to nerve ischemia. However, late signs, such as paralysis in absence of peripheral pulse, are indicators of an irreversible permanent damage. Management shouldn't wait for these late signs. Compartment syndrome is a surgical emergency which requires immediate fasciotomy to decompress the involved compartments and save the affected limb. Open fractures, defined as fracture associated with a skin wound leading to direct communication between the fracture hematoma and the external environment. It's the most prone to infection and considerably differs in both the management and prognosis. Open fracture is a surgical emergency which requires multidisciplinary team management. Antibiotics and surgical management depend on the classification type. So we have types according to Gustilo grading of open fractures: type 1, 2, and 3. Type 1, wound less than or equals to 1 cm with minimal soft tissue injury, clean puncture wound. Type 2, the wound between 1 to 10 cm with moderate soft tissue injury. 3, wound more than 10 cm with extensive soft tissue damage. Farm injuries are type 3 regardless of the wound type. A for type 3A can be covered by local muscle or skin. Type 3B requiring extensive soft tissue coverage, rotational or free flap. Type 3C associated vascular injury regardless of the wound size. Fracture healing. Bone healing is a complex sequential set of events which depends on many factors. It's broadly divided into biological factors related to presence of a good blood supply, healthy bone cells from the endosteum and periosteum, mechanical factors related to the stability of the fractured bone ends in front of each other. It occurs in one of the two ways according to the mechanical stability of the fracture. Healing by primary intention, direct, occurs when anatomical fracture reduction and together with rigid and total mechanical stabilization of the fracture, absolute stability, involving direct osteonal bone remodeling without involvement of a transitional tissue between fracture ends, healing without callus formation. Common example after open reduction and plate fixation of intra-articular fractures, while healing by secondary intention or indirect healing occur when a gap exists between the fracture ends or relative degree of mechanical stabilization, relative stability. The fracture passes by 5 successive stages. The key component is the formation of a transitional tissue called callus. This callus is responsible for bridging the gaps and providing more stability to the fracture ends. Common examples after closed reduction and fixation with the cast for humerus fractures or closed reduction and intramedullary fixation of mid-shaft femoral or tibial fractures. The stages: 1. Hematoma, 2. Inflammation, 3. Callus formation, 4. Consolidation, and 5. Remodeling. 1. Hematoma occurs immediately. Tissue destruction and hematoma forms around the fractured ends. 2. Inflammation within 8 hours. Acute inflammatory reaction with proliferation of stem cells under the periosteum and within the medullary canal. 3. Callus formation within 2 to 3 weeks. The proliferating cells, which are potentially chondrogenic and osteogenic, start forming immature and disorganized fibro-osteocartilaginous tissue named soft callus or woven bone. Callus bridges the gap and stabilizes bone end. 4. Consolidation, month, involving endochondral ossification and transforms the soft callus into hard, well-organized bone. 5. Remodeling. It occurs within years. Continuous process of alternating bone removal and formation, reshaping of the bone to fit its original shape and function. Factors affecting union of the fractures, as mentioned before. Several factors affect the process of bone healing, broadly categorized as factors affecting the biological or the mechanical environment of the fracture. General factors, all related to biological fracture environment, general condition, generalized disease such as diabetes, have poor healing power, age, children heal in a much shorter time than adults, smoking, nicotine decreases healing, drugs, certain drugs affect repair process. Common examples, systemic corticosteroids are associated with high non-union rates, vitamin D and calcium supplements help the repair process. Local factors, vascularity of the fragments, certain fractures are notorious for delayed healing due to the tenuous vascularity. Common examples are fractures of the scaphoid, talus, lower thirds of the tibia and ulna, and intracapsular neck of the femur. Position of the fragments, impaction enhances the healing, whereas distraction delays. Immobilization of the fragments, this is a vital step for proper healing. Lack of proper immobilization, unstable fixation, leads to repeated movement at the fracture site, interfering with process of union. Fracture pattern, comminuted fractures are more prone to non-union. Infection, destroying the granulation tissue and the healing tissue. And finally, bone quality. Treatment is to be significantly stressed upon that managing a fracture should be a part of managing traumatized patient as a whole. Emergency primary treatment begins with initial trauma survey and resuscitation, airway, breathing, circulation, disability, and exposure. Controlling pain should be done immediately by strong analgesics, fracture alignment, and temporary stabilization by local splint or traction starting from the accident site. Controlling bleeding. All fractures are associated with blood loss, which might be significant, as in fractures of the major long bones, pelvis, and open fractures. Fracture pelvis or shaft of the femur can lose up to 2 liters in the fracture hematoma. Direct pressure is applied to control local bleeding from an open fracture. Avoid tourniquet application, as it may lead to more tissue ischemia and damage. Controlling infection. In case of an open fracture, emergency room management should be verifying the wound, then cover with sterile dressing or at least clean material. Remove the gross debris only. Gentle wound irrigation with copious amount of saline. Avoid any forceful pressure lavage. Intravenous antibiotics administration as soon as possible. Tetanus prophylaxis administration as soon as possible according to the vaccination history and the severity of the wound. Assessment of the fractures, associated injuries, bladder injuries and fracture pelvis, as well as the neurovascular status. Definitive treatment. A specialist carries definitive fracture treatment following the 3 principles: reduction, fixation, and rehabilitation. Reduction. Definition. Reduction is the action of restoration of the normal anatomical or perhaps acceptable relationship between the fractured fragments. Reduction is not necessary as in minimally displaced fractures, and when the displacement is within acceptable range and will not cause any functional disability, such as most fractures in the clavicle. Types. Anatomical reduction, involving perfect restoration of the fractured fragments morphology, favoring direct bone healing. Indicated in intra-articular and simple pattern fractures. Functional reduction, indicated in extra-articular fractures, especially comminuted, favoring indirect bone healing, involving restoration of the bone length, alignment, and rotation, LAR, without precise reduction of the fractured fragments. Time. Early reduction before the limb gets swollen is desirable. Urgent reduction is mandatory if the fracture is complicated by vascular or nerve injury. Methods. Reduction can be done using direct or indirect techniques. Indirect or closed reduction, involving reduction without directly opening and viewing the fracture. Manipulation of the fractured fragments is done using traction by weights or gravity, skin or skeletal traction, or hanging casts, or manual closed manipulation under anesthesia and muscle relaxation. Direct or open reduction, involving opening the fracture side, then directly holding and manipulating the fractured fragments, mainly indicated after failure of closed reduction and when perfect anatomical reduction is mandatory. Fixation. Definition. Fixation implies the action of holding of the reduced fracture fragments in the same position until solid healing occurs. Types. Fixation stability may be absolute or relative. Absolute fixation stability refers to rigid fixation, avoiding any motion between fractured fragments, favoring direct bone healing, indicated in intra-articular fractures and simple pattern fractures after direct anatomical reduction. Relative fixation stability referring to fixation allowing some degree of motion, micromotion, between fractured fragments without loss of fracture reduction, favoring indirect bone healing indicated in extra-articular fractures, especially comminuted after indirect functional reduction. Methods: external fixation, including non-operative casts, splints, and tractions, and operative external fixator methods. All these methods lead to relative fixation stability. Casts and splints, different types of materials and shapes exist. Plaster of Paris and fiberglass are the most used materials. Proper cotton padding underneath is necessary to avoid complications. Should fix to the joints adjacent to the fracture site for immobilization. Advantages: cheap, safe, and doesn't need extensive facilities. Disadvantages are joint stiffness, muscular atrophy due to prolonged immobilization, pressure source due to improper padding, loss of reduction. Compartment syndrome may occur due to tissue edema within the inelastic cast, leading to intracompartmental rise of pressure. To avoid this serious complication, the limb should be well padded, the cast shouldn't be tightly applied, and good observation on the circulation in the periphery of the limb should be continued for at least the first 24 hours after cast application. In cases of any suspicion, the cast should be immediately bivalved or removed. Traction: it may be either skin or skeletal traction, allowing the use of heavier weights. External fixation: special pins are introduced in the bone, proximal and distal to the site of the fracture, and the pins are connected to a special external frame. Different frame types and shapes exist. This method of fixation is strongly indicated in infected and open, potentially contaminated fractures. It avoids operative internal fixation with the possibility of infection, colonization on the implants, as well as it leaves the wound accessible for inspection and dressing. Rapid and closed application is another advantage. This makes it the procedure of choice in emergency management of hemodynamically unstable fracture pelvis and damage control orthopedics (DCO). Internal fixation, done through operative intervention. Wide range of fixation devices exists that can be used in different ways to achieve whether rigid or relative construct stability. Common examples in intra-articular fracture distal radius and proximal tibia extending to the joint, open reduction and internal fixation (ORIF), using plate and screws, is usually done to achieve direct bone healing and immediate joints mobilization. In extra-articular fracture, tibial and femoral shaft fractures, closed reduction and internal fixation CRIF, using interlocking nails, is usually done to achieve indirect bone healing. Main advantages are that there is no possibility of loss of reduction with early mobilization and rehabilitation. Main disadvantages are that it's highly demanding technique with high cost, requiring special operative skills and setting to avoid the potential complications, especially post-operative infection and non-union. Rehabilitation aim at restoration of function of the injured part and the patient as a whole. From the beginning, all unsplinted joints and muscles must be mobilized and kept active by regular exercises. Internal fixation allows immediate joints mobilization and muscle exercises. Joint stiffness after removal of casts and splints is treated by gradual exercise programs. In general, active exercises are preferred, and aggressive passive exercises might be deterrents in moving the fracture ends or more seriously causing myositis ossificans. Definitive open fracture treatment. Open fracture treatment is an urgent surgical intervention. The essentials of management are proper wound debridement and copious lavage. In the operation room under anesthesia, wound margins are excised till healthy skin edges. Wound extension, adequate exposure, and deep fascia is widely opened. Foreign bodies, necrotic muscles, and tissues are removed. Bone fragments without soft tissue attachments and blood supply are removed. Copious wound irrigation used in average 3 liters of saline are used for each successive GS type. Type 1, 3 liters, 2, 6 liters, 3, 9 liters. In severe contamination or delayed surgery, the skin and fascia shouldn't be closed immediately and best left open to be closed after the second look. Stabilization of the fracture, preferably by external fixator. Early wound coverage, combined with plastic surgery to cover the bone and prevent further contamination. According to the extent of soft tissues loss, options include primary closure, secondary closure, split or full thickness graft, and flap coverage. And this concludes our part for today.